I have been asked to present balloon sinus dilation, or better known sinuplasty, indications and technique and evidence. I do want to thank the editors, David Gudis, Jivian Lee, and David Kennedy, for inviting me to make this presentation. My name is Michael Setzen, and I practice in Great Neck, New York. I'm a clinical professor of otolaryngology at Weill Cornell Medical College in Manhattan, New York. And this chapter and presentation was created in conjunction with my colleague, Waleed Abuzeid, who's an associate professor of otolaryngology at the University of Washington in Seattle. Waleed and I have nothing to disclose. What are the objectives of this presentation? We'll talk about the indications for balloon sinus dilation, the economics, some of the controversies thereabout, intraoperative and office-based balloon sinus dilation. What are the implications since COVID-19 has been around? And what evidence exists for balloon sinus dilation? Are there any complications? And what are the future directions? So what are the indications for balloon sinus dilation? Well, a brief overview will let it be known that it can be performed in the office or in the OR. It does not remove mucosa or partitions. It creates limited changes in osteal dimensions, namely the sinus ostia, and it can be used only for frontal, maxillary, and sphenoid sinuses. It cannot be used for the ethmoid sinuses, and traditional ethmoid surgery needs to be carried out for the ethmoid sinuses. What are the benefits of balloon sinus dilation or sinuplasty? It's catheter-based. It's minimally invasive and particularly excellent for the elderly and debilitated. It is safe and effective. There's minimal bleeding and is particularly useful in those patients who may be on anticoagulants or have a bleeding disorder. There's a fast recovery time with people going back to work, school, and play within a day or two, and it does not limit treatment options. It can be done in the office or the OR together with traditional endoscopic sinus surgery. So you may want to use the balloon in one or two sinuses and traditional endoscopic surgery in other sinuses. And it can be either office-based or in the OR. And as I've said, it can be used as a hybrid in conjunction with endoscopic sinus surgery. Balloon sinus dilation is controversial. And during this presentation, we'll try to go through the pros and cons. There is data suggesting significant cost benefits related to balloon sinus dilation. Namely, there's lower facility and resource costs versus endoscopic sinus surgery, which is done in an OR, necessitating all the operating room staff and the anesthesiology staff and all the expenses that can incur. There's less post-operative care and less clinic visits, favorable impact on direct disease-related costs such as medical therapy, physician visits, and this also decreases costs and expenses. And there is a favorable impact on indirect economic costs, namely the rapid return to work where the individual can be productive and therefore increased productivity. And these indirect economic costs can be quite significant. Given this context, is usage and overusage really an issue? And we'll discuss this a little later. So I would highly recommend that everybody get hold of the clinical consensus statement put out in the Academy Journal, Otolaryngology Head and Neck Surgery in 2018, entitled Clinical Consensus Statement, Balloon Dilation of the Sinuses. This was a consensus statement put out by Academy experts, and this should be the guideline by which most adhere to when doing balloon sinus dilation. And this is something that insurance companies are indeed adhering to. And I'll go through some of the highlights. Balloon sinus dilation is not appropriate without both symptoms and positive CT findings. It's not appropriate for patients with symptoms and a CAT scan that does not show disease. So you need both a history of sinus disease, you need some findings on endoscopy, and most important, you need some CT changes, in particular in that sinus that you're going to operate on. And of course, a CAT scan is required before balloon sinus dilation, as this is an operative procedure, and you wouldn't do endoscopic sinus surgery without a CT, and the same applies with balloon dilation. And this was recommended to prevent those doctors that would just see a patient in the office and immediately take out the balloon and start doing balloon dilation. So you need a CAT scan before you do this. It's not appropriate for the management of headache or sleep apnea unless those patients meet the criteria for chronic rhinosinusitis or recurrent acute rhinosinusitis. So they may have headache or sleep apnea, but they need to also have chronic rhinosinusitis with symptoms, signs, and CAT scan changes. It does have a role, as I've said, in recurrent acute rhinosinusitis, provided you adhere to the guidelines put out by the Academy as to exactly what is recurrent acute rhinosinusitis. It does play a role in patients with persistent disease after endoscopic sinus surgery. So you may have undergone endoscopic sinus surgery and the patient comes back and there may be narrowing of one or two sinuses, be it a sphenoid or frontal or a maxillary, and it's okay to use the balloon to dilate that sinus that may have narrowed down. And it is appropriate as an adjunct procedure when performing endoscopic sinus surgery in what's called a hybrid type procedure for chronic rhinosinusitis without polyps. So you can do balloon dilation, as I've said, on some sinuses and endoscopic sinus surgery on other sinuses. So what are the implications for deviating from these statements? Well, you could be audited by the insurance company. You won't be reimbursed if it doesn't adhere to the guidelines put out by the insurance company, whereby many of them are requiring that you have a history of sinus disease with the appropriate symptoms, and the CAT scan does show narrowing of the sinus to be dilated and some mucosal thickening within that sinus. And what this is doing is it's preventing doctors from just ballooning all 6 sinuses. So you need to balloon only those sinuses that are appropriately indicated. And obviously, if you abuse the system, there may be an OPMC investigation, namely the Office of Professional Misconduct may investigate you. When is it absolutely not indicated? When there are complications of sinusitis, be it orbital or intracranial complications, and if there's diffuse nasal polyposis. Can you use it in diagnoses other than chronic rhinosinusitis where CT findings may be absent? Generally not, but in recurrent acute rhinosinusitis, sometimes one does the CAT scan between the 4 episodes, and at that time, the CAT scan may be negative. And at this time, you may have to have a discussion with the insurance company, with your patient, and let it be known you indeed do have recurrent acute rhinosinusitis, and the CAT scan was done at a time when you were not symptomatic, and therefore, for that reason, it was normal, and therefore it may be okay to balloon the necessary sinuses. COVID-19 has definitely impacted the approach to balloon sinus dilation. Initially, patients were afraid to have anything done surgically, and then they started gravitating towards the office for this procedure because they rather wanted it done in an office setting rather than to go to a hospital, because they were concerned that COVID-19 may be present in these hospital settings. And physicians do need to address COVID-19 in their patients ahead of time, test them, and obviously dress appropriately to protect yourself and your staff. The economics of balloon dilation have been controversial as well. And ever since CPT codes were created, there was an increased usage of the balloon procedure. And, this is for obvious reasons, that initially physicians didn't want to do it if it was an unlisted code, because an unlisted code sometimes doesn't generate income. And furthermore, it creates a lot of paperwork, and physicians didn't want to have to, take care of the expense of the balloon and then not get reimbursed appropriately. And obviously, new technology does get embraced, and if physicians, are finding that it does indeed have good outcomes, they may want to start using it. And so that's initially, what did happen. Obviously, industry was pushing it initially, and physicians started embracing it. And many of the patients that did undergo endoscopic sinus surgery were then rather recommended a balloon dilation procedure. And many a patient did say, you know what, if this is a conservative procedure, particularly if it can be done in an office setting, maybe I'll undergo that procedure. So I think these are some of the reasons why there was a significant increase, soon after 2011 and more so after 2014. Now, obviously, the incidence of chronic rhinosinusitis hasn't increased much, but there has been the significant usage of balloon dilation as opposed to endoscopic sinus surgery. And reimbursement has been quite significant for the balloon procedures. And partly this was due to the fact that when the balloons were created, the codes were created, they took into effect the fact that the physician had to lay out the expense for the balloon, which is in and around $1,500. And with that in mind, they said, well, if you're going to do a balloon dilation of a sinus, the doctor at least needs to recoup the $1,500 plus the expense of doing the procedure in the office and any necessary malpractice issues that may be related, because that's how they created the relative value of the CPT code. What they didn't anticipate was that the physician could use one balloon for more than one sinus. But this has been dealt with by the fact that when you do a second procedure, usually the second procedure is decreased in value. And furthermore, with the clinical consensus statement and the quite rigid recommendations as to when you can balloon sinuses, physicians will not be able to balloon sinuses that do not adhere to these recommendations. And insurance carriers have also abided by these recommendations. So the days of ballooning all 6 sinuses are no longer a factor, and you have to balloon only those sinuses that are indicated. So who is driving the increase in this utilization? Initially, it was industry. Industry was responsible for driving this, and they introduced physicians to this. They then introduced their patients to it. And I would say today it's being more driven by both physicians who've incorporated this into their practices, in particular when doing an in-office procedure. And then patients are aware of it, having read about it online and having seen that a conservative sinus procedure can be done in the luxury of one's office under local anesthesia with minimal time away from work, school, or play. So I think it was industry initially, and today it's more the patient and the physician. And as I've said, it's the fact that patients can see that a conservative procedure can be done rather than have to undergo a general anesthetic procedure in an operating room. And it's particularly those physicians doing it in the office setting that are encouraging this, if indicated, for their patients. Is there overuse? As I've said, initially there may have been overuse, but I think with the Academy Clinical Consensus Statement and insurance reimbursement guidelines, I think this is being addressed as I've been said. I don't think industry is driving it anymore, and the consensus statements, I do believe, will modify physician behavior. So I think the American Academy of Otolaryngology needs to be complimented for drawing up this clinical consensus statement. What about office balloon dilation? Why do we do it in the office? Well, it's an integral step between medical therapy and a formal endoscopic sinus surgery in an operating room under general anesthesia, if necessary. We can avoid general anesthesia. It's potentially an effective intervention in a comfortable setting, namely your office. There's favorable patient recovery and minimal time away, as I've said, from work, school, and play. There is symptom improvement, as has been shown on the many medical articles that have been published. It's easy to schedule with minimal wait time. So we can see the patient in the office on a Monday, and possibly by Wednesday or Thursday, one can do the procedure in the office setting. And the patient, I think, today is the driving force for this in-office approach. They want it in the luxury and comfort of one's office. Let's look at 3 scenarios. We'll first look at a sphenoid sinus dilation. I would think of the sinuses, the one that's most difficult to anesthetize is the sphenoid sinus, but you do need to inject either the sphenopalatine area or in and around the ostium. You need to apply topical pledgets, and I'll go into this in a short while. So here we're using one of the rigid balloons. We're lateralizing the superior and middle turbinate. We're gently popping into the natural ostium of the sphenoid sinus. One is dilating the sphenoid sinus. There's minimal bleeding, and it's a very comfortable way of dilating the sphenoid sinus. You can use surgical navigation if you have that available in your office. Many of the insurance carriers are not reimbursing for the use of in-office navigation, but you know, one can try get reimbursement. What about balloon dilation of the frontal sinus? Generally, this one is most probably the next most difficult, but if you do find the uncinate process and you gently elevate it up and you've anesthetized the patient appropriately, it is easy to find the frontal sinus drainage pathway. You need to be gentle when inserting the device, in particular if it's one of the more rigid devices, because you don't want to enter the orbit or cranium. So let's run this video, and one will see here's the middle turbinate, here's the uncinate process, and there we try to elevate up the uncinate process, release any attachments of the uncinate to the frontal sinus area and the ethmoid, so that the balloon can be gently passed, as we can see, under the uncinate process, heading towards the frontal sinus drainage pathway area. As I've said, you can use surgical navigation or transillumination. I like to use transillumination and see how the forehead transilluminates, and then I know that I'm in the frontal sinus. Once in the frontal sinus, you dilate it for 10 seconds at 10 psi, and you can serially dilate the frontal until you have a good wide opening into the frontal sinus. If there were pus in that frontal sinus, we may see pus exuding from the area. And you can see that this is, quite easily done with minimal bleeding. And then finally, what about the maxillary sinus? I think this is the easiest of the sinuses to dilate. Generally, what I'll do again is you need good anesthesia, elevate up the uncinate process, and find the natural ostium of the maxillary sinus. Don't enter an accessory sinus, because this is not going to be of any benefit. So here we'll see we find the natural ostium of the maxillary sinus. I generally use a 30-degree if need be, raise up the uncinate process. We can see transillumination in the maxillary sinus, and then dilate the maxillary sinus ostium 10 psi for 10 seconds, and you can do multiple dilatations until you have a good wide open area into the maxillary sinus. And if this area were to have pus, it would drain out appropriately. And we can see once again that also is quite an easy procedure to do. So with respect to evidence, there have been many publications. I'll just highlight briefly a few, and I will give you a summary of the references and suggested readings and sources at the end of the presentation. So what evidence does exist? Firstly, for in-office balloon dilation, Karen Feeloff and others did look at office balloon dilation. This was a prospective, multi-center, single-arm study. They looked at 203 patients that were refractory to medical therapy. 47% of them had maxillary disease, 45% and 7% sphenoid disease. Some of them did require a polypectomy and ethmoid surgery as part of a hybrid procedure. And technically, there was almost 94% technical success that they were able to enter the appropriate sinus. One patient did have a limited self-limiting periorbital swelling. 82% of them did tolerate it. There was a mean 2-day return to work. There was improved post-operative SNOT 20 and Lund-Mackay scores at 24 weeks. And the pre-op ethmoid disease did resolve in 64% of the cases, and 87% did improve with no specific ethmoid intervention, even though balloon dilation was carried out. Two other studies, one by Cutler et al. And Bagazi et al., both in the American Journal of Rhinology and Allergy, first one in 2013 and the second one in 2014. And these were prospective multi-center randomized controlled trials. They looked at adult patients with CRS. It was mainly maxillary with possibly ethmoid disease. And endoscopic sinus surgery was carried out in 42 of the patients and balloon dilation in 50 patients. And they had a 12-month follow-up. And statistically, there was significant improvement in both, and they were similar. The findings were similar. Reduced rhinosinusitis episodes were similarly reduced in both arms. Radiographic osteopatency, there was 96.7% patency in the balloon arm, as opposed to 98.7% in the endoscopic sinus arm. So they were comparable. There were no complications, and there was one revision surgery in each group. The balloon arm did have fewer post-operative debridements and bleeding. There's post-operative pain, faster recovery, as one would anticipate. And one of the downfalls of this, of course, is that it was industry-sponsored, and two of the authors were paid consultants or stockholders. What about another publication by Payne et al. When they looked at medical therapy as opposed to sinus surgery, and they used the balloon dilation. And this was a prospective, multi-center, non-randomized study. They looked at 198 patients. CRS was refractory to medical therapy. They did continue medical therapy in one arm as opposed to balloon sinus dilation in another arm. 28% of them were done in the OR, the rest were done in the office. Some of them did have adjunctive procedures, namely ethmoidectomy, polypectomy, turbinate reduction, or septoplasty, and they did do a 24-week follow-up. Technically, there was 97% technical success rate, so they were able to get into the sinuses that needed to be dilated. There was one TIA post-op, one post-op sinus infection, and the balloon sinus group did have significant improvement in quality of life scores as opposed to the medical therapy arm. And there was significant improvement in the SNOT 20 as well. And this held true with the subgroup analysis of balloon patients who had no adjunctive procedures as opposed to the medical therapy. Another downfall, of course, of this is that it was industry sponsored and some of the authors were consultants or employees. Yet another publication looking at balloon sinus dilation versus medical therapy for recurrent acute rhinosinusitis. And this was a paper by Sikand et al. In the International Forum of Allergy and Rhinology, February 2019. And I would encourage you to look at this one as well. And they too found that balloon sinus dilation with medical therapy proved to be superior to medical therapy alone for these patients. And I would encourage you to read this. So let's talk about office balloon dilation and how do we prepare for it. So preoperatively, you do need to get insurance approval and discuss with the patient some of the direct possible costs. You must get informed consent and treat this just like a regular surgical procedure, such as an endoscopic procedure, where you will discuss with the patient that you may have bleeding, you may have orbital or intracranial risks. And furthermore, I would also tell them that if this procedure weren't effective, that they may need to undergo endoscopic sinus procedure in an operating room under general anesthesia. You may want to offer them sedatives, anxiolytics, or analgesics ahead of time to relax them, to cover any possible discomfort that they may have. Topical anesthetics are important. Initially, we applied it all topically on pledgets. Now I am spraying them again and using topical pledgets. We need to be aware of COVID-19. These patients need to be tested ahead of time. And obviously, if they have COVID, don't do the procedure. Intraoperatively, we monitor these patients. I like to use a pulse oximeter. I watch the O2 and pulse rate, keep it on their finger. You do need to be prepared should they have a catastrophic cardiopulmonary event, so that you may need to intubate them or resuscitate them. You need basic sinus instruments. You need to have good visualization, namely endoscopes and monitors, appropriate balloon devices, and have epistaxis management available should the patient bleed. COVID-19 precautions for both you, the patient, and the staff need to be instituted. And post-operatively, you can give them the necessary medications, be it steroids, antibiotics, painkillers, whatever your choice is. And then the patients need to, take it easy for the first day. I have them be driven in and driven home. I do not want them driven home after this procedure, because in case, God forbid, they were to be involved in an accident, you may be held liable for any untoward effects that might have occurred. So the topical anesthesia that I like is 1% niacin and 4% lidocaine, either sprayed in or placed on pledgets. And topical 4% tetracaine is another good one on pledgets placed in the osteomeatal complex where you're going to work. Some of us do use topical cocaine either in the OR or in the office setting, but it does require a lot of legal aspects to it and paper trails and documentation, so many don't want to use it. And furthermore, you can only use it in the medically healthy patient, not a patient that has a cardiac history. I usually inject the patient, and I inject with 1% lidocaine with 1 in 200,000 epinephrine. I like the 1 in 200,000 epinephrine because I don't want the patient having tachycardia, but I won't inject those patients that may have a cardiac history. I'll then rely just solely on topical anesthesia. Just a couple of examples of patients. This was a patient that had flown into the New York area, had a cold. They were in severe discomfort. They wanted to fly back home. And we did a CT and found that they did have disease in the sphenoid sinus. And there was concern as to whether or not it would be appropriate for them, to fly back home with this kind of pus in the sphenoid sinus. So medical therapy was used, and it didn't address the issue. So this patient consented to having an in-office balloon sinus dilation of both sphenoid sinuses, and a short while thereafter was able to fly back home. What about this patient? A 34-year-old male with nasal congestion, post-nasal drip, facial pain, had failed appropriate medical therapy, no nasal polyps, and on CT you see disease in the maxillary sinus area, a little bit in the ethmoid area. And this patient had failed optimal medical therapy and was willing to undergo a balloon dilation of both maxillary sinuses. And this was a simple option for the patient. We did have this done, and the ethmoid disease did clear as well, and the patient has done well. And what about a patient with this kind of maxillary sinus disease? A 45-year-old female, left cheek discomfort, nasal congestion, post-nasal drip, middle meatal edema on endoscopy, no polyps, failed appropriate treatment, and was having quite significant discomfort in that cheek. And one, presented to her, you could either have this done under general anesthesia in an operating room, or we can take care of this in the office. And she consented to the in-office balloon dilation. We appropriately numbed her up with topical medication, injected the area, medialized the uncinate, the middle turbinate, found the uncinate process, entered the maxillary sinus with balloon dilation, inflated the balloon, and lo and behold, there was a significant amount of pus that exuded out from the sinus. And that was actually a great case to have done in an office setting. We made a wide opening with the balloon, drained out all the pus, sent it off for bacteriology. There was no soft tissue involvement in there. And if indeed there was, then one would need to take appropriate tissue and submit it for histology. And this then becomes more of an endoscopic sinus procedure rather than a balloon procedure. And you need to code this then as a endoscopic sinus procedure rather than a balloon procedure. But this patient only had purulent material. And what about a sphenoid situation like this, where this patient has total opacification of the left sphenoid? Once again, this would be an opportunity for the patient to have this either under general or in the office. And once again, if they consented to have this in the office setting, appropriately anesthetize the patient. You can see the ostium of the sphenoid. You can enter this with or without navigation. And then, once you enter the sphenoid, if there's disease within the sphenoid, be it polyps or soft tissue, this needs to be submitted for histology to rule out anything of significance, in particular something neoplastic. So keep in mind that it's all very well to do the balloon dilation, but if indeed there is disease there, this must be biopsied, removed, and submitted for histology. So how severe is too severe to balloon? As I've said, if you have a complication of sinusitis, don't balloon that patient. Furthermore, if there is diffuse nasal polyposis, that's not a case to balloon. And the minimal amount of disease for balloon dilation would be one where the patient is symptomatic, they have some osteal narrowing on endoscopy and on CT, more than endoscopy, with some mucosal thickening within the sinus to be involved. So sinuses to be involved need narrowing on endoscopy, but more important, narrowing on CT with disease within that sinus to be dilated. Now, what about using balloon dilation when you have a poor surgical outcome? Now, obviously, if the surgery was reasonable and there was failure of say, one or two sinuses, I think, as I said this earlier, be it the maxillary, frontal, or sphenoid, then it is appropriate to dilate that involved sinus that may be causing the patient discomfort. And that could be done either in the operating room or the office. And if you did have a failed balloon sinus procedure, if you did the procedure, I would say rather resort to traditional endoscopic sinus surgery in an operating room under general anesthesia, which is I like, rather than repeating that balloon dilation again. On the other hand, if the patient came to you and somebody else had done the balloon dilation, then I may, feel, let's try the balloon dilation in my hands one more time. So that would be the only time I would use balloon dilation a second time. What about balloon dilation in the operating room? Well, there's been a significant amount of literature to support its use, and it's used for serial dilation of frontal recess stenosis, to collapse obstructing type 3 or 4 cells, to find the natural frontal outflow tract in primary or revision surgery. So it's being used as an ostium seeker. And I like to use this, in many cases when I'm doing the frontal, I use the balloon to locate the frontal sinuses. I think it's a nice way and a very safe way before you do the frontal sinus surgery. Dilation of a laterally obstructed supraorbital ethmoid cell, and patients with a bleeding diathesis or significant morbidity, you may actually want to bring them to the operating room, have general anesthesia on standby, do it under local anesthesia, and do it exactly as if you were doing it in your office, but you're doing it in the operating room because you're concerned about their cardiopulmonary pathology. So Josh Levy et al. Had a publication in the Otolaryngology Head and Neck Surgery Journal in 2016, where 17 articles met inclusion criteria. Outcomes were good, as were Lund-Mackay scores being good. And they looked at these publications and found that the 6-month SNOT-22, the 12-month SNOT-22 for each item were quite significantly reduced. So they looked at the SNOT-20 items there, nasal obstruction, postnasal drip, and each item did show a reduction. So they found that balloon dilation in the office did have a positive outcome. And the Lund-Mackay scores as well did show reduction. And this is a rather messy slide, but it's the slide that will show the most of the 17 articles that they used in this publication to show the improvement in the SNOT-22 at 6 and 12 month and the improved Lund-Mackay scores. So how do these results compare to endoscopic sinus surgery? In the appropriate indicated cases, they compare favorably. So if it's a rather minor case of chronic rhinosinusitis without polyps or recurrent acute rhinosinusitis that may have failed optimal and appropriate medical therapy, it's reasonable to offer the balloons or endoscopic sinus surgery, but the results do compare favorably. They don't compare favorably, obviously, in those patients with significant sinus disease, especially with numerous nasal polyps. It doesn't have a role there, and there you need endoscopic sinus surgery. Are there scenarios where balloon sinus dilation is obviously advantageous? Yes, in those patients with significant comorbidities that you don't want to take them to the operating room and use general anesthesia. So you may want to do a simple in-office balloon dilation, particularly if they are on anticoagulants, or if they're fearful about going to an operating room, or if they don't want to go to an operating room. Yes, in those very early, simple cases of chronic sinus disease, balloon dilation may be advantageous. And is it fair to expect this high level of evidence now being thrust upon balloon dilation when it did not occur for endoscopic sinus surgery? Yes. Today, the standards are much higher than they were 25 years ago when endoscopic sinus surgery was first introduced. And fortunately, endoscopic sinus surgery has withstood the test of time based on the multiple publications with good patient outcomes, but there haven't been randomized controlled trials as there are being done for balloon sinus dilation. So yes, there is a different standard, and fortunately, balloon sinus dilation has withstood the new standard and has demonstrated high level of evidence improving those indicated cases. Are there complications? You know, initially people said, you know, the balloon is safe, there are no complications, but you do need to keep in mind, discuss with patients that complications can occur, and this is exactly, as I've said, like endoscopic sinus surgery. This paper by Her et al. In otolaryngology head and neck surgery in 2020 did find cases that were submitted, you know, did have complications. Between 2008 and 2018, 211 adverse events were submitted to the appropriate industry manufacturer. And what's interesting is only half of these adverse events were patient-related. The other half were device-related. They couldn't get into the appropriate sinus. There was balloon failure, instrument failure. But of those 48.3% that were patient-related, some had CSF leak, 37 of them of the 211, eye swelling, 30 patients, and epistaxis, 12 patients. So I think one does need to keep in mind that there are certain risks that can occur when using balloons, and discuss this with your patient. And when you sign the consent, this must be discussed with the patient. And another situation where this article by Chaban et al., they looked at outcomes and complications of balloon and conventional endoscopic sinus surgery, and they found in their publication in the American Journal of Rhinology in 2018, in one commercial database of 2,851 balloon sinus dilations, that there were complications, skull base complications 0.4%, as opposed to what was occurring in endoscopic sinus surgery, 0.2 to 0.4%, orbital complications 3%, as opposed to endoscopic sinus surgery, which had 0.1 to 3.5%, and bleeding complications 2%. So there are indeed complications that can occur with patients undergoing balloon dilation, and please keep this in mind when getting consent with your patients. So what are the future directions with respect to balloon dilation? There are favorable outcomes in appropriately selected patients, especially in-office balloon dilation. And I think as rhinology is gravitating more and more to the office, the in-office balloon dilation will become a significant tool that the rhinologist will offer to patients with the appropriately selected cases of chronic rhinosinusitis and recurrent acute rhinosinusitis. There will need to be further research to delineate the effectiveness and appropriateness of balloon sinus dilation in specific patient populations, and practitioners should remain vigilant about overuse, abuse, and the potential ramifications thereof. I think it's important that we abide by the clinical consensus statement of the Academy. Keep in mind that insurance companies have their own guidelines, and if you adhere to this, balloon dilation will continue to be used appropriately with good outcomes. This is the suggested reading and reference list, and the source that Dr. Abuzeid and I have used when drawing up this chapter for the textbook Rhinology Worldwide video textbook. And I would encourage you to take note of this, review it, and utilize this as you move forward with balloon dilation, whether you use it in the OR or in the operating room. On behalf of Dr. Abuzeid and myself, I do want to thank the editors, David Goodis, Javianne Lee, and David Kennedy, for inviting us to make this presentation.